Good evening to all the aspirants present here. We do have our faculty over here. The today's topic is diabetes mellitus, and the speaker that we have here today is Dr. Boudhayan Das Munshi, who is a associate professor and general medicine in AIMS Kalyani. Thank you, sir, for being with us. Some more students will be joining us soon. You may start now. Thank you.
Very good evening to everyone. I would like to thank Farz Academy and Asif Das, specifically Dr. Asif Iqbal, for giving me the opportunity to interact with students in this forum and discuss a very common thing which links all the people in the following picture. So if you can identify, this is Wasim Akram, this is Mrs. Shushma Swaraj, the former minister in the government, and an actress whom you all know. So there is something common in between, and the common link between all three of them is a condition known as diabetes mellitus. Now, is it the same in all or not? That we'll be discussing over the next 1 hour to 1 hour 15 minutes. Since our target is primarily the postgraduates in general medicine, so my discussion will have certain theoretical aspects which are also required from the theoretical exam point of view and also for your viva voce. So we'll be trying to learn the following, and at the end of the session, you all should be able to list the diagnostic criteria of diabetes and apply this criteria for the diagnosis of diabetes mellitus, know about the classification of diabetes mellitus as per the American Diabetes Association 2025 latest guidelines, and give an outline of the comprehensive medical evaluation which is required in your patient with diabetes, and also talk a bit about the targets during treatment. And I'll be discussing them under the following headings. So without wasting any further time, let's talk about the number. We're all fond of numbers, and numbers make a difference. So just to begin with, the Indian statistics way back a few years, maybe a few years back, as given by the ICMR India study, where diabetes in India was, or patients with diabetes was almost 101 million, while pre-diabetes patients were 136 million. So why this value becomes important? This value becomes important because we need to know the magnitude of the condition which we are dealing with. And that is why the importance of this topic, because this is not only important on a regular day-to-day basis, but also a very important public health issue at present. Now, when the patient comes to your OPD and asks, do I have diabetes mellitus or not? So it's very important to realize that the diagnosis of diabetes mellitus is done by a biochemical criteria. So let's go through this 3 case vignettes and try to understand whether these patients are actually suffering from diabetes or not. A 40-year-old obese lady with a family history of type 2 diabetes presents to the OPD as a part of a pre-surgical workup with reports of fasting plasma glucose of 160 milligrams per deciliter, postprandial plasma glucose of 250 milligrams per deciliter, and HbA1c of 8.3. Next case scenario, a similar sort of scenario, only the values have changed. And here the values are that the fasting is 111, postprandial plasma glucose is 181, while the HbA1c is 6.3. The third case scenario, again almost similar sort of a history, but the values make a difference. And here lies the importance of knowing the biochemical diagnostic criteria for diagnosis diagnosis of diabetes mellitus in the non-pregnant individual. The fasting plasma glucose is 151, postprandial plasma glucose or 2-hour OGTT is 191, and HbA1c is 6.3. So those participants who have joined right now, can you put it on the chat box? What could be the diagnosis in 1, 2, and 3? So I'll just go back. This is case scenario number 1. This is case scenario number 2. And this is case scenario number 3. So could you kindly type in the chat box? We'll give you about 30 seconds maybe. You can write 1, diagnosis, 2 diagnosis, and 3 diagnosis. So do we have some answers on the chat box? Or should I go back to the case vignettes? So do we have some answers on the chat box?
All the aspirants, you can
Okay.
put your answers or any question in the chat box. It's an interactive session, you may answer.
Can you show the values again?
Okay,
Yes,
so this is case scenario number 1. This is case scenario number 2, while this is case scenario number 3. So we have
Okay.
answered by Dr. Dipashri, who says that 1 is
Num-
type 2 diabetes mellitus, and second scenario is pre-diabetes. So we have answers also coming up from Dr. Shiv Kumar, Dr. Ishani Basu. So 3 no one has attempted yet. So let's
Number
come to
3 is fasting hyperglycemia. Number 3.
Okay. It's better if we have the answers on the chat box. We can interact later on at the end. So, okay. So with this, let us come to the diagnostic criteria. So how do we diagnose prediabetes in the non-pregnant individual? So here, the HbA1c is somewhere between the normal and the abnormal. It's like the border zone, where the HbA1c is between 5.7 to 6.4%. Fasting plasma glucose is 100 to 125, and the 2-hour plasma glucose post 75 grams OGTT is 140 to 199. This let's do what will be the criteria in case of diabetes. So if 6.4 was the borderline there, when it crosses 6.5 or is on 6.5 HbA1c, it becomes diabetes. Fasting here has to cross or be equal to 126, while the 2-hour post plasma glucose post OGTT with 75 grams is more than equal to 200. Now, what is very important out here in this slide is to remember what is fasting. The definition of fasting is that there should be no calorie intake for at least 8 hours. So if someone is consuming date, and therefore that can be considered as having a fasting state. But if someone consumes a fruit juice and then goes on to take it within the 8 hours, that is not a fasting sample. So that should be remembered by everyone. The other point which should be remembered by everyone is that if the classical symptoms of hyperglycemia or there is an hyperglycemic crisis in the form of diabetic ketoacidosis or HHS, which we'll be talking probably in the next class, and there is a random plasma glucose, a single value of more than equal to 200 is fine. However, let's come back to the case scenarios. If we see the case scenarios, the case scenario number 1 and 2 were clear cut. That there was diabetes and there was pre-diabetes in case scenario 1 and 2. But if we go, the fasting plasma glucose was actually higher than the normal, or it was in the diabetic range. However, HbA1c and the plasma glucose post OGTT were in the pre-diabetes range. Now, if we have such aberrant values, one aberrant value, it's important to repeat that value again after a certain period of time and then cross-check whether the person is actually having a persistence of the abnormal values or not for labeling the person as having diabetes or pre-diabetes or whatever we want to label as fall after that condition. Now, when we know that the biochemical criteria for diagnosing diabetes is this, in whom should we apply this criteria, especially if the persons are asymptomatic? So if we go to the document from ADA, that is the American Diabetes Association, we'll come to know that individuals who are probably overweight or obese, having a higher BMI, with first degree relatives with diabetes, or coming from an ethnicity which predisposes to a higher risk of diabetes, or with cardiovascular disease history, or with hypertension or dyslipidemia, or with polycystic ovary syndrome, with physical inactivity maybe, are more predisposed. Now, As per the American criteria, there is a talk of the cutoff age of 35 years for screening in those who are asymptomatic. But in India, in the Asian Indian phenotype, probably screening needs to start at a younger age. And therefore, probably last year, there was a drive whether 25 years could be a cutoff or not. As of now, certain recommendations are for a cutoff of 30 years. However, it should be remembered that in Indians or in Asian Indian phenotype, it probably starts at a younger age group. So, someone labeled the first case
One
scenario as
question. One question, please.
we'll come to questions at the end, sir.
No. In
We'll
the
come,
third case, I
we'll
just
come
want
to
to.
questions at the end, sir. We'll come to the
Oh,
questions at the end. You can keep your questions posted on the chat box. We'll come to your questions at the end, sir. So if we talk about the type of diabetes which the patient or the person is suffering from, someone had mentioned that it is type 2. Now, whether it's type 2 or type 1, there are certain things which are often asked in the theory exam maybe and in the viva, and therefore we need to know what is to be written in the exam if such a question comes. But why is it also important? Because it is also important because the majority of the patients we see are the type 2 diabetes mellitus, and the remaining will be a much lesser percentage than what the type 2 actually present to us. And therefore, knowing the difference and what treatment we can offer becomes important. So if we go to the classification, this is a broad that there will be type 1, type 2, a gestational diabetes, and certain specific types of diabetes due to other causes. Now, type 1 diabetes can have its various stages depending upon the passage through normoglycemia, dysglycemia, and overt hyperglycemia in the presence of autoimmunity in most scenarios, while gestational diabetes mellitus has a separate diagnostic criteria by itself. We have taken this document from the ADA. However, for Indians, for us, it's important to remember that the Diabetes and Pregnancy Study Group of India, they have mentioned that if the OGTT or 75 grams glucose administration and 1 hour post is more than 140, then, sorry, the 2 hour is more than 140, then the diagnosis of gestational diabetes can be made. Now, coming to the specific types of diabetes mellitus due to other causes, we should remember that the genetic defects of beta cell function form an important probable question for all our postgraduates. They include the names of the various MODIs or maturity onset diabetes of the young. But the genetic forms of diabetes also include the neonatal forms of diabetes, which are supposed to be mentioned in the theory exam. Coming to the genetic defects in insulin action, you will have lots of names coming up, which as a beginner, probably it will be difficult for all of you and all of us to remember and go into the nitty-gritties of each. So we'll try to remember the broad headings rather than go into the specifics when we discuss this problem. The diseases of the endocrine pancreas is something I'll be coming to specifically after some time. The endocrinopathies, the coexistence of other hormonal abnormalities can predispose to the occurrence of diabetes, or whether the diabetes is secondary to drugs. Very important amongst this is the usage or the chronic usage of glucocorticoids or steroids, as we talk about, which could predispose to the occurrence of drug-induced diabetes. Infections, though I have just listed congenital rubella and cytomegalovirus, but we have gone through the age of the COVID, and we know that COVID is associated with the occurrence of diabetes mellitus also. Uncommon forms of immune-mediated diabetes, you will probably read in the newspapers about certain celebrities who have this. To name them, Stiffman syndrome and anti-insulin receptor antibodies. But we are not going to go into the depth of all these because these are very rare. But for the purpose of completing your theory exam answer, I have listed this out here. And the others remain the genetic syndromes. There are multiple genetic syndromes, but you could just remember probably the name Wolfram syndrome from this out here. Now, let us come to the clustered classification of type 2 diabetes mellitus, which includes 6 parameters and 5 clusters. So the parameters based on which the clusters have been defined include the age of at diagnosis, the body mass index, the presence or the positivity or absence of the anti-GAD or the GAD antibody, the HbA1c at diagnosis, the beta cell function and C-peptide, the beta cell reserve and the C-peptide, and the insulin resistance. To come to the clusters, let's not go into the details of them, but please let us remember the names at this point of time. The severe autoimmune diabetes where the GAD antibody remains positive. The severe insulin deficient diabetes where the GAD antibody remains negative. The severe insulin resistant diabetes where the GAD antibody again remains negative. The mild obesity related diabetes and the mild age related diabetes. So we are not going to go into the details of this because this can be a separate class in itself. But for the sake of completion of your answer, let us remember at least the slide which we have gone through previously. This slide at least is to be remembered for writing the theory exam. Now, we have talked about different forms of diabetes. This is in a nutshell about what genetics can help in identifying or not in identifying. So we have the monogenic forms and the polygenic forms, and this is how this can be classified with in a simplified form as taken from the literature. Now, let us identify what we are. That is the Asian Indian phenotype, where the individuals have low birth weight, that is the thin fat Indians, and we are more predisposed to the occurrence of type 2 diabetes mellitus at an earlier age, with occurrence of cardiovascular disease also at a younger age, with characteristic dyslipidemia, with low vitamin D and low vitamin B12, the insulin resistance being greater and there being a greater beta cell defect. So this is the Asian Indian phenotype where the visceral fat plays a major role in the occurrence of this sort of a phenomenon. There's something known as the YY paradox in relation to this, where individuals of the Asian Indian phenotype, despite having the same BMI, may be more predisposed to all the complex cardiovascular diseases or the occurrence of diabetes and at a younger age group. Fat distribution and risk of diabetes. Which one is better? Whether it's the pear-shaped or is it the apple-shaped? So it also depends upon the presence of the fat distribution in the body, pear being probably more healthier than the apple. So the pear-shaped distribution probably has a better prognosis or better outcome with the risk of diabetes compared to an apple. There is the metabolic syndrome, the word which is often used for the exam purpose. Previously, numerous other terms have been used, where the impaired or the abnormal glucose values along with the presence of hypertension or the treatment, whether the patient is on treatment with hypertension, along with dyslipidemia, certain parameters like triglycerides and HDL, along with the elevated waist circumference, and depending upon the country-specific definitions, they can be clubbed together and be called as the metabolic syndrome. Now let's come to a term which often is asked as a question nowadays. That is the type 3C diabetes. That is diabetes where the pancreas is predominantly affected, or the pancreas gets affected first by some condition which can include any of these as listed in the picture, and the person goes on to develop a condition of diabetes. That has also been classified under certain terms which we'll be discussing in the next 10 minutes. Let's come to the case vignette number 4. where we have a 35-year-old male presenting with a picture which probably resembles something known as diabetic ketoacidosis, where there's elevated blood glucose with positive urine ketones with an acidotic picture and bicarbonate being lower. But what has been observed is that the GAD antibodies in this patient was not elevated, or the antibodies were not at all elevated. There was the C-peptide was there, it was not deficient or not low. And the person had a phenotype where he was obese with abdominal obesity with acanthosis nigricans. And there are certain features which probably show that the patient might have been having insulin resistance, like acanthosis nigricans, or the occurrence of abdominal adiposity, the visceral fat which we were talking about. So is this a type 1 or a type 2 which we are dealing with? So probably it's not a type 1 diabetes mellitus. The patient received insulin initially. However, the patient could be shifted to OHs and subsequently was managed with diet and lifestyle only. And the HbA1c was maintained with just this OHs and diet and lifestyle. So what could this be actually? So this could actually be a ketosis-prone diabetes, or something known as a term given as Flatbush diabetes. Now, this ketosis-prone diabetes could be classified with the help of the parameters which we have written on the slide. However, what is to be remembered out here is that the ketosis-prone diabetes patients, with the example of Flatbush diabetes specifically, which I have shown, tend to occur more in the Afro-Americans who are obese. Let's look at this picture: the presence or absence of antibodies, autoantibodies, and the preservation of beta cell function. Now, if we have a look at this picture, we can gauge that there could be 4 possible combinations which we could be handling when we see patients. So in this patient of ours, why Flatbush? Because that's an area in New York where this was identified probably for the first time and came into prominence. But because this type of patients are actually having a more severe type of type 2 diabetes with greater loss of insulin action on the target tissues or in the target tissues, but phenotypically they are usually middle-aged, overweight, or mildly obese, and more likely to be males who require aggressive insulin therapy initially, but later on can manage without insulin in itself. When we have discussed this Flatbush diabetes, let us also discuss about the latent autoimmune diabetes of the adults or of the young. So the words become LADA or lady, usually present at an age 30 years and above, but it could be present at a slightly younger age group also, who have a personal or a family history of autoimmunity with reduced frequency of metabolic syndrome compared to the type 2. What is important in this is, while in Flatbush, the patients required insulin in the beginning because of a picture of diabetic ketoacidosis, and later on they could be managed without insulin. Patients with latent autoimmune diabetes of adults or the young actually require insulin or do not require insulin in the initial phases, but they might go into insulin requirement very soon after a few months. So what's the take-home message from the following case vignette? That all patients with diabetic ketoacidosis do not have type 1 diabetes mellitus. That's the take-home message from these group of slides. Let's come to the case vignette 5, where we have a 17-year-old. So this is a young female, non-vegetarian of low socioeconomic status, who presented to the emergency with recurrent abdominal pain, with polyuria, polydipsia, and a low BMI. Blood sugars were elevated. However, ketones in the urine were negative and ABG was normal. So what could this be? The amylase and lipase were normal, but here an abdominal imaging showed the presence of probable opacities in the X-ray, which could suggest that the patient was probably suffering from something known as fibrocalculous pancreatic diabetes. Now, we have talked about the ketosis prone diabetes. Here we need to remember that we are probably dealing with something known as a ketosis resistant diabetes. That is, in such patients, despite a phenotype which mimics probably the so-called traditionally taught type 1 diabetes mellitus patients, this patient was thin, young aged. However, despite high blood glucose levels, the patient did not go into ketosis. And it's important that there are certain mechanisms and certain predisposing factors or theories which mention that why this ketosis resistant diabetes could develop in the following patients. There's a diagnostic criteria for it, initially identified in the tropical countries, and therefore, but what is important is that the role of imaging cannot be neglected in patients of diabetes. That is something which all of us should remember, that sometimes the imaging of the abdomen becomes important for the diagnosis of the condition which the patient is having. And therefore, imaging can form an important role in this subset of patients who resemble a traditional classical type 1 diabetes phenotypically, however, do not land up in a decay and subsequently go on to or are found to have pancreatic calculi on imaging. There are multiple so-called etiologies or theories why these things happen, and there are differences to differentiate it from the traditional or classical alcoholic pancreatitis. However, what is kept to be remembered is that whenever you are dealing with diabetes in the young, keep this condition in the mind. We have said it happens in the tropical countries. It's not just a phenomenon in Kerala, Orissa, or Bengal. Remember, it can happen in any part of the country. And where we are working presently also, we are having a large number of patients of this sort of a condition presenting to us and getting diagnosed for the first time out here. Now, why this is also important? Because this can sometimes be associated with increased risk of malignancy. And that is why this condition needs to be identified and probably taken care of from an early stage. So what's the take-home message from this case vignette? That the role of imaging in diabetes of the young cannot be forgotten, and that FCPD has an increased risk of malignancy in the future. So if we have known this classification and diagnosis, next comes when the patient is in your OPD, how to evaluate or how to go about the comprehensive evaluation of the patient. I'll just have a look at the chat box before we go to, we have finished about half an hour, and I can see the answers on the chat box, and mostly everyone has answered it correctly for the questions which were asked previously. So I'll just go back again to my slides. At this point of time, let me just share a few case scenarios or stories which you would probably be interested in. Whenever you see patients, young patients, always have an open mind. Why? Because we are at this point of time getting type 2 diabetes even in the very young patients. For example, patients presenting at 10 years, 12 years, 14 years also are presenting with type 2 diabetes mellitus. So traditionally, we have been taught that type 1 happens in the young, type 2 happens at a later age group. But please remember, these boundaries for diagnosis, that the age at which this diagnosis is being made, are in today's world always do not hold true. So you should take or evaluate a patient in details. And the evaluation of a patient starts with interaction with the patient. And the interaction with the patient starts with what we have all been taught from the third semester of our MBBS life, that is history taking and detailed history taking and examination. In today's era also, detailed history taking and examination cannot have any replacement. And therefore, when the biochemical diagnosis has been confirmed, and probably we are trying to classify the diabetes based on the history and the clinical examination, there are multiple other steps which have to be taken into consideration. These include a lot of factors, but out here, when we are treating in India, and as postgraduates who are completing from different institutes across India, you may be working in a government institutes, you may be working in private institutes, you may be working in the uh, most well equipped cities which have everything, or you may be working in the rural areas where everything might not be available to you. You have to remember that history taking and clinical examination has no other substitute, and stepwise evaluation becomes important. So, how can we go about it? We can go about it with a detailed history. We have to take into consideration the characteristics at the onset, the previous treatment plans, if any, and assess the severity and try to probably identify the cause. A detailed family history. Why the family history again becomes important? Because the first degree relatives we have already identified are at an increased risk even in asymptomatic individuals. Also, the family tree may need to be drawn when we are dealing with some of the genetic conditions like MODY, which we had talked about. This is the maturity onset diabetes of the young. Now, in assessing the patient, we need to go for detailed evaluation, and comorbidities like obesity, which has been the talk of the town in the last 2 months because of the guidelines which have come out both in Lancet and also from the team from Dr. Mishra and Dr. Naval Vikram sir from Delhi. I think this topic has been dealt with in many classes, but therefore I'm not going into the details of obesity today. However, it is equally important to identify this obesity from day one itself, and whether the patient is having any high blood pressure, and look out for complications of this condition, which we'll be discussing at the end of today's class from the very beginning. So, what could they be? We'll come to it very soon. But whenever you are dealing with diabetes, please remember, what will you be more careful about? Is it hyperglycemia you're more worried about, or hypoglycemia? So, could you please answer on the chat box? If you are dealing with a patient of diabetes, what should you be more worried about? Is it hypoglycemia or is it hyperglycemia? So, can we have a few answers? So, all have agreed and unanimously agreed, whoever has typed in, that it is the hypoglycemia which we are more worried about. And that's why in the next class, when we talk about, we'll go into hypoglycemia in more details and discuss about its pros and cons. However, while history taking at the bedside, please remember to ask about episodes of hypoglycemia, whose details we can always talk about in the next class in details before you think about stepping up or stepping down a treatment. Other referrals often become important, but the eye examination should never be forgotten whenever you diagnose a patient with diabetes. So please remember, history taking is important, history of hypoglycemia is important, but the eye should not be forgotten. We talked about obesity, metabolic surgery becomes important, behavioral factors. When we talk about obesity or diabetes, the age-old concept of increase intake and less weight loss or less output is often talked about, though that theory might not hold true completely in today's era when we know about the various factors which go into obesity and the subsequent occurrence of type 2 diabetes mellitus. But it is very important to identify the eating patterns and the weight management. Is it only important in type 2 diabetes? No, it is also important in type 1. A very commonly talked about problem is whether a patient who has type 1 diabetes should he or she be leading a life just like any other person. Yes, that person should be allowed to develop and grow just like any other person. So it's not that they should be barred or debarred from attending parties or any social gatherings which they think they should attend. But there are ways in which they can be managed, and that is supposed to be taught, emphasized, re emphasized, and enforced when the management of this condition takes place. That is type 1 diabetes mellitus. We talk about sleep, and in the background of obesity and obstructive sleep apnea, the sleep behavior history and the addiction history becomes important. Management of various forms of diabetes is incomplete without talking about the plan or treatment with drugs. Often it happens that we don't talk about diet and lifestyle. However, we directly start writing a prescription containing medicines. Yes, medicines are important. Medicines form one of the major backbones of treatment. But diet and lifestyle should also never be forgotten when we talk about the management of diabetes. And the details about the medications we'll be talking about also in the next class. We are in the era of artificial intelligence. We are in the era of ChatGPT. We are in the era of modern equipments and machines which have tailored the diabetes management or management of chronic diseases in all possible new ways. And over here, the importance of this recognition of the role of technology in the management of chronic conditions, including diabetes, should not be forgotten by any of us. But remember, this is something I wanted to talk about because probably today in the OPD and probably with someone who is close to me, probably a family member of mine, I've just come to understand that social supports become important. I am working in a place known as Ames Kalyani, where Kalyani is a town just about a few hours or few hours, maybe 1.5 hours from Kolkata, where we have a lot of uh, persons, a lot of patients who are in the elderly age group. Their children, their family members might all be working outside Kalyani, maybe somewhere within the country or maybe abroad. So they often lead a life which is quite alone, maybe, and do not have a so-called supportive social structure. Often they don't have people to interact with in person. So in management of any chronic disease, ensuring the adherence to treatment can be done if the adequate social support is also there. Otherwise, the disease and its management in the long run, because as I said, that we, the Asian Indians, get diagnosed at an earlier age, and probably we start having complications at an earlier age, that the management might become a bit heavy on the patients because of the lack of this social support which they might be having, whether it is at workplace, whether it is at home, or whether it is in relation to even type 1 diabetes, where support in schools. Just think of a scenario that one has to inject insulin in the abdomen. So it is often looked at on as a taboo in several places, even now in today's era, in several places. Maybe not in Bengal always, but all across the country in several places. And that is something which needs to be addressed at various levels for proper management of the condition. As I mentioned, history taking alone is not sufficient. A detailed physical examination is important. I'll be sharing a pro forma which is there with me, given to me by my teachers at various institutes, including from JIPMA, what we used to use, in my postgraduate institute, and also at CMC Vellore, where I have gone for several trainings. So I'll be sharing that paper after the session with the organizers, and they'll be sharing with you. So you could be using one of them, or you could be designing a OPD booklet or maybe a paper for monitoring the patients as per your convenience. However, certain investigations can never be forgotten while in the OPD, and amongst that, palpating the pulse and also checking out for the blood pressure cannot be neglected when a patient of diabetes has come. Several religious scriptures mention that the importance of foot or the care of the foot when guests come at your home. But remember, foot examination also becomes important when a patient of diabetes comes into your OPD or into your clinic or in the IPD. Not only just a visual inspection, but looking out for neuropathy or vasculopathy can be important with the use of equipments as enumerated in this picture. You might have an advanced setup where you could go for temperature testing also, but at least for postgraduates, it would be my request that kindly examine the feet whenever you have a patient of diabetes. One of the most senior teachers of this subject, whom we consider as a stalwart and as a guru for us in this subject, when I went for training under him, the first thing he always did was come and just examine the foot of the person. He never bothered about anything else but check the foot and also the footwear of the person. So my request or humble submission to our postgraduates would be that if our teachers can check the foot and the footwear whenever they examine such a patient at such a senior stage, I think we should also be doing that at every stage or for every patient we examine. Now coming to the physical examination, as I said that support system becomes important. So the mental health problems also can become important in these patients, and assessment for them can be important. Now the question, before we write the medications, what investigations are to be done for the patient? As we have already seen that by HbA1c, fasting plasma glucose, and a 2 hours OGTT would be the starting point. But when we have diagnosed and probably based on the clinical history and the examination, we're trying to profile or label a person as having type 1 or type 2, what other investigations could we go in for? Those include the renal function test, where the serum creatinine and the estimated glomerular filtration rate becomes important. The liver function tests, especially the ALT and maybe the albumin also sometimes, the lipid profile, and in type 1 diabetes patients and sometimes in type 2 diabetes patients above a certain age, the thyroid evaluation can also become important. Patients taking metformin for a prolonged period should be evaluated for vitamin B12. And if I can share my experience, recent times when we are actually evaluating patients of vitamin B12 on those with in patients on metformin, we have actually found the vitamin B12 levels to come as low. Now, whether it's a true marker of vitamin B12 deficiency or not, that is something we can debate it out or talk about it sometime later, which does not fall within the purview of this class today. But remember, at least as per the guidelines, let's go for that step of vitamin B12 as a beginning step in these patients on metformin, as this is probably drug which is used in majority of your patients, because the majority of your patients will be the type 2 diabetes mellitus patients. What else could be important are the serum electrolytes, especially in patients who are having or who are on concomitant AC inhibitors or ARBs, and evaluation of the other electrolytes based on the appropriate clinical scenario or the complication the patient is suffering from. Assessment of complications becomes important. Kidney and the heart always have their own place. Liver is not to be forgotten. Eyes definitely are important, but the peripheral vascular system or the peripheral vascular areas should also not be taken for granted. So if we know that, what do we need to achieve? And there comes the importance of learning about targets. Just like when we were students, we always used to have targets in what time we want to achieve certain goals or we want to achieve certain targets. Similarly, in case of management of type 2 diabetes or in case of management of diabetes per se, we have certain targets. And I'll be discussing some of them very soon. Treatment plans can vary based on diet, lifestyle, pharmacologic treatment, but also with emergence of obesity, surgical management could also form an important part. Referrals to other specialists can be important, especially if indicated. But what should not be forgotten by all of you is, do not forget to check the eye in type 2 diabetes mellitus patients on diagnosis. I repeat myself, in patients of type 2 diabetes mellitus, do not forget to check the eye at the very first instance when you have an encounter with the patient. Other complications also need to be evaluated. Now let us move on to the last part of today's discussion, that is a few aspects about the monitoring and the outline of the treatment which we are going to discuss in the next class. So monitoring could be with the investigations which we talked about, that is a prescription having HbA1c, fasting plasma glucose and postprandial or the postprandial plasma glucose being mentioned, measured at every 3 to 6 months dosing has happened, or in certain subset of patients, monitoring using a glucometer or a CGMS or a continuous glucose monitoring system could be done. However, what are our targets? First, let us come to the HbA1c target. Should we keep it stringent or should we keep it relaxed? So, for non-pregnant individuals, adults who do not have too many complications, too many comorbidities, with a short duration of diabetes, with lower risk of hypoglycemia, and who are not having a lot of systemic complications involving the heart or the vascular territories or the kidneys or weight issues, think about a stricter target, that is something less than 7. Certain guidelines give it less than 6.5. But what is important for all of you to remember is, targets can be lower, however, hypoglycemia should not happen. That is why I asked you that question. Which one is important, hyper or hypo more? Lower targets, lower target. It would be helpful if someone could just pause your microphone. Some sounds are coming. So lower targets could be taken into consideration. However, hypos should be avoided. For the elderly, for those with disabilities, for those who are unlikely to live for a very long time, that is not having or having limited life expectancy with severe life limiting comorbidities, do not go for a very strict target. Let them have that component to life also which goes beyond the glycemic control. Certain values which postgraduates should remember, or this table needs to be remembered, that if you are looking at an HbA1c of 6% or 7%, what's the value or average value are you expecting the glucose to be there so that you get this HbA1c of 7 or 6.5. So this is the chart which will help you to identify. Just remember this 7 value of HbA1c, if you can see the left hand corner and with the cursor on, and this average value of 154 milligrams per deciliter. This is pretty fine if you can remember. Now, coming to those who are not using already as discussed, the fasting or the preprandial plasma glucose could be about 80 to 130 and the postprandial could be less than 180. However, as I have mentioned and as I have emphasized again and again, please remember these targets could be achieved in those whom I have discussed, but do not cause hypoglycemia. Again, I am emphasizing do not cause hypoglycemia while trying to achieve the lower end of the targets. That is what is most important for all of us to remember. If you're using a CGMS or if you're monitoring quite frequently, then time in range, a basic concept that how much percentage of the time that a person spends with their blood glucose in the target range. The values vary for different subgroups of people, but I'll just talk about if you see the right hand corner of your screen, for most people with type 1 or type 2, a value of 70 to 180 would be a preferable one, where 70% of the day, if it is kept within that range, that would be quite preferable, especially if a CGMS is being used. Lower values or higher values obviously have to be kept at a minimum. Lower values should be avoided more than the higher because of the problems which could arise associated with hypoglycemia, which we'll be talking about in the next class in further details. So just have a look at this. This is just an average. HbA1c basically reflects the average of your last 3 months control, where the majority of the contribution may be coming from the month, just 1 month back, then from the second month, and then from what was there 3 months back. Maybe a 40-40-20 ratio of contribution, just an average value, which I'm saying from one of the textbooks. But just look at this. I always used to say that when I was a child, we were fond of traveling to Sikkim and Darjeeling. One of the roads was very bumpy and had lots of ups and downs. Another road had its ups and downs, but that was less. So, what did we prefer to travel by? We always preferred a road, or even now, when I travel from Kolkata to Kalyani via the Kalyani Expressway, I always prefer a road which will have its less ups and downs and a smooth ride. So, similarly, the HbA1c, if you see out here, in the 3 pictures, if you see the picture on the left hand of the screen, it has its highs and its lows. However, that on the right side where it is written 100% has a less bumpy ride and the life to be smooth and not have its extreme bads and goods. Similarly, even in HbA1c attainment with the glycemic control, we want a more steady control with less fluctuations so that we have a better optimum control with less chances of maybe the toxicities or the damage which can happen because of this glycemic variability. We have talked about the targets. We have identified or tried to understand how HbA1c of 7 could be there in all the 3 case scenarios. However, the journey may not be smooth in all the 3 scenarios. And what we prefer is a smooth ride. We need to identify before we end today's class is about the complications which we'll be talking about in details and why these complications become important for the exam point of view. Whether you were in the undergraduate period or whether you are in the postgraduate period or whether you are a practitioner who handles diabetic ketoacidosis or emergencies in your hospitals, Remember, diabetic ketoacidosis and hyperglycemic hyperosmolar state and hypoglycemia are very important, not only for the purpose of exams, but also because you will have lots of patients with these conditions coming to your emergencies or your OPD in the setup you're working in. I for sure get to experience this very regularly. Even now, as I'm talking, probably 1 hour back when I was coming back from my hospital, all three were there in our wards as because we have the patients coming in. But probably when you are handling, if you are in OPD setup, probably you will have less of the emergencies coming, but you will definitely have patients who have had a history of hypoglycemia, that is the fall in blood glucose, and therefore you need to identify this condition well in advance. The complications or the vascular complications, the macrovascular, where we have the coronary heart disease or the coronary artery disease, the cerebrovascular disease, and the peripheral vascular disease, versus the microvascular complications, where we have the kidney involvement, the retinal involvement, and the peripheral neuropathy. The microvascular complications, if we club together, that is diabetic nephropathy, retinopathy, and peripheral neuropathy, can also be called as the cryopathies. But are the complications restricted to the traditional ones only? No. We now talk about complications with diabetes in the form of the cognitive disabilities, the functional disabilities, the musculoskeletal system involvements, the liver being a major site, with today also one of the papers coming out from the team at New Delhi, and infections playing a major role, whether you are dealing with UTIs or whether you're dealing with that is urinary tract infections or the respiratory tract infections. So in a nutshell, we tend to deal with a lot of complications which are either arising from the condition or because of the chronicity of the condition or as a result of the condition. So when we talk about treatment and we talk about complications, how can we forget the medications and their side effects? The traditional or the more commonly used ones, metformin, the SGLT2 inhibitors, the DPP4 inhibitors. All of us are not blessed to be working in a setup where we can advise expensive medications, and therefore majority of us may not be able to write prescriptions containing semaglutide or liraglutide or tirzepatide at the places we are working in. So we have to understand also diabetes in the social context. I've said that it affects the mind, it affects the health, but it's also a problem which affects the society, and therefore we have to understand the extent to which we can do for our patients and the limitations which we have in the various setups which we have. The other drugs which can be commonly used, especially with those who are not so economically well-to-do off, pioglitazone, the sulfonylureas, commonly glimepiride, gliclazide, and glipizide are the ones we use. Gliclazide is probably something now not readily available. Probably people like us have used once upon a time, now our prescriptions probably don't reflect the use of glibenclamide anymore. Insulin is something which we talk about in the pathogenesis, but we also talk about it in treatment. Whether we are talking about the latest developments or the age-old insulins. How to give, how to store, how to properly use it, every postgraduate trainee should learn about it. Why this is important? I might share one example with you all, that when I was a fresh pass out from my institute, we went to a conference where we had postgraduates who had passed already, but they were awaiting the completion of the 3-year tenure, who had come out there. So we might be knowing a lot about the theoretical aspect of insulin, which we have to write down in the exam. But majority, sadly enough, did not know how the insulin vial looks like or how the insulin cartridge looks like, and which pen is to be used or which syringe is to be used for the specific concentration of insulin which we have. So, not only knowing about insulin is important, but you should all go back to your patients or to your wards and see the medication strip maybe, or the insulin vials, or the drugs at the bedside, how they look, what is the content, and how they can be administered best. We often rely on the nursing officers or nursing team to do it, but first we should all learn by ourselves firsthand. This is something which was talked about by Dr. Ralph DeFronzo several years back, maybe about 16 years back, and how the ominous octet was addressed pathophysiologically by the various pharmacological agents. We're not going into the details of it right now, but this will form an important part of our discussion in the next class when we talk about the pathogenesis of type 2 diabetes mellitus and the treatments we have to offer for the condition. And with this, I will end today's discussion because it's about to be 1 hour. And for remembering, please remember that before we talk about treating related to diabetes mellitus, we need to establish, go for or identify at least which type of diabetes it could be, because our treatments will vary, which we'll be discussing again in the next class in details, based on the type of diabetes. And the evaluation is not one size fits all. Please remember, one size does not fit all when we talk about evaluation of diabetes mellitus, and therefore it's imperative for all of us to probably choose our investigations wisely when we go about evaluating the specific type of diabetes we are having. Monitoring the patient, adjusting the doses, and screening for complications depending upon what type of diabetes we are handling is of paramount importance, and tailoring the treatment based on the comorbidities and the complications is also necessary for ensuring the health of the patient, but most importantly, what we all try to achieve in our lives, that is the important or the good quality of life in our patients of diabetes. So with this, I again thank you all for a patient hearing for the last 1 hour, and thank the organizers for giving us the opportunity, or giving me this opportunity, to discuss some of the aspects about diabetes mellitus. This topic in itself can go on for classes, and maybe even 20 classes may not be sufficient. However, I have tried to put forward certain important things which are important from an exam point of view, from your MCQ entrance point of view, and also for treating your patients or managing your patients at the bedside. We have not gone into the details of treatment in today's class, but we'll be going into that and how we can choose our medications from the wide basket which we have of the oral drugs and the injectables, and probably give a better outcome to our patients. So thank you very much. Over to the organizers, please.
Thank you, sir, for being with us. I would like the aspirants, if you have any question, you may ask now.
Well,
So I
myself,
can see
Dr.
a few
Prasad.
questions. I can see a few questions on the chat box. So people have asked about hypoglycemic unawareness. So we'll be going into hypoglycemic unawareness, and we'll be going into HAF, or hypoglycemia associated autonomic dysfunction. We'll be going into that in the next class. So we'll be discussing that in further details. About occurrence of asymptomatic hypoglycemia, yes, please remember that patients do not always have to be symptomatic for whatever biochemical diagnosis we make. At the very beginning, I mentioned the case scenario that the 40-year-old lady whom we talked about, had actually gone for a pre-surgical workup. So before that, maybe the person was not aware of the type of or whether the person was really having diabetes or not. Maybe a blood examination could just help you to. Can we have the microphones off for the participants? May I request the participants to kindly keep their microphones off? Okay. So basically, in the case scenario with which we started, we have to remember that symptoms, the presence of symptoms is always a boon, but you will often have patients landing up to you for the treatment of diabetes, where it has been diagnosed maybe as a part of a pre-surgical workup, or maybe as a part of annual health checkup, which is done by several companies, and the patient or the person may not be having any complaints. So asymptomatic presentations of the disease is a known entity. And similarly, when you have hypoglycemia, so we'll talk about the values of hypoglycemia, the levels of hypoglycemia in the next class, but the threshold at which symptoms will arise in an individual is not the same for everyone. And therefore, in certain individuals, you might have a hypoglycemia, or you might have a blood sugar of maybe 50 milligrams per deciliter in the patient on insulin. However, the patient may not be complaining of anything. And as someone has asked about the autonomic dysfunction, so that's something we have to keep in mind and probably be more worried. And that's why I mentioned, or probably asked the question in the very beginning, that whether hyperglycemia or hypoglycemia is of paramount importance. Both are important. Let's just not say that only hyperglycemia is important. Hypoglycemia means not just hypoglycemia is important, even hyperglycemia is important. But if you are given only one option to choose, hypoglycemia is something which we'll be more worried about because of the associated complications which can arise and the difficulties or challenges in management which can happen in those patients. So could we have more questions on the chat box?
Yes.
Please feel free to ask.
I just want to highlight one very important thing. In the third case which you have shown, myself, Dr. Ghushal, a senior consultant in medicine. Now,
Thank you,
you have
sir,
shown the
for
fasting you have shown as 151. And HbA1c, there are at times most centers don't do by HPLC, that is the high performance liquid chromatography. So HbA1c is always fallacious. And there are new markers coming up like fructosamine and albumin, which are more specific for a very short term. As HbA1c gives results for the last 3 to 6 months, they give for say 3 weeks, 4 weeks. So I had a case just like a similar your third case. Even after repetition, the results came as the same, and it has to be treated as a case of diabetes and fasting hyperglycemia. You have to do a real-time CGMS, and I did that patient CGMS, and it was found that all the fasting values were high, and HbA1c carries very little importance in 2025. You have to see the real-time CGMS, which is more specific. This is my first take-home message to you. And secondly, my question to you is, in India, the cost of GAD antibodies is very, very high. So how will you diagnose a patient of type 1 diabetes, where the cost of these markers are very, very expensive?
So thank you, sir, for your inputs. So coming to the first discussion on the importance of HbA1c, yes, HbA1c can be increased or decreased as a result of several factors. Patients of anemia, patients with on treatment for anemia, they can have their HbA1c values being altered because of multiple factors. You could have patients who have HbA1c in the normal range, however, fasting is on the higher side. Now, I'll just give one more input. While yes, HbA1c is an average, that's why I mentioned at the very beginnings that you could have a mathematical value in your mind that 40%, suppose it's a reflection of your last 3 months, suppose. So month 1, that is from today to 1 month back, contribution was 40%. From that 1 month back to 2 months back, the contribution was around 40%, and contribution from month 2 to month 3, the time period, was around 20%. So if we consider that, maybe the increase in the HbA1c, which is being reflected by this recent 40% might not cross the threshold for the so-called biochemical labeling of diabetes mellitus, as already highlighted by Sir. So in such scenarios, yes, this fasting abnormality could be a precursor to the ultimate diagnosis of overt diabetes mellitus, which can happen. But we should also be aware of certain conditions where only the fasting hyperglycemia might be there, and the patients may not progress very rapidly to the overt diabetes mellitus or the overt type 2 diabetes mellitus. So there are these genetic forms of diabetes, which we have alluded to during our discussion, in the form of MODY or maturity onset diabetes of the young, some of which could be characterized by the presence of hyperglycemia. So in such scenarios, the progression may not happen very rapidly to overt type 2 or overt diabetes mellitus. Therefore, we need to be aware of that scenario also, where or certain subsections of the population where the fasting value may remain altered, and the HbA1c could be normal, and it could continue to be normal also despite the fasting blood glucose being on the higher side. But whenever in doubt and whenever the values don't point to a conclusive diagnosis, repeating is not something which should be avoided, and that should be taken into consideration, considering again the socioeconomic status of the patient. And since we have talked about the socioeconomic status of the patient, it comes to the second, or that brings me to the second question which Sir has asked. That is, in a country of ours where patients might not have access to diagnostic kits or technologies at a very cheaper rate, yes, they may not be having access to them at all places. Maybe in certain government, if you have access to certain government setups where these are available, you can definitely go ahead with it. Or if you know people out there and can get the patient to get those tests done, then definitely it could be helpful for the patients. But what we see in majority of our type 1 diabetes mellitus, as I mentioned in one of my slides, that you could have stages 1, 2, and 3, if you remember in those slides. So that overt type stage 3 may not be there in all the patients. Agreed? Now, in our patients, as we mentioned that the patients are often poor, there are multiple government schemes in several hospitals, especially in the government institutes, where patients get insulin free of cost. Now, coming to how the diagnosis can be made or confirmed, as I mentioned before, that one of the commonest presentations of type 1 diabetes mellitus is a presentation to the emergency, and to the emergency in the form of diabetic ketoacidosis. Now, diabetic ketoacidosis, as I mentioned at the very in the middle of my discussion, that diagnosis of diabetic ketoacidosis is not equal to type 1 diabetes. But in a young patient, maybe somewhere where we had the second case of FCPD, a 17-year-old girl who presents with we have history of weight loss, with polyuria, polyphagia, with recurrent infections, and presence in a dehydrated state. And if we have the facility of ABG at least, we could go ahead and diagnose the presence of acidosis and metabolic acidosis, and more importantly, the presence of high anion gap metabolic acidosis. In that background, if we can go for checking of the fasting C-peptide and stimulated C-peptide after achieving glycemic control, we might be able to diagnose the occurrence of type 1. Now, as we have also read in literature, that type 1 could have its variety where the antibody may be positive or it may also be negative in certain scenarios. So, our important aspect is to identify whether the patients would be requiring insulin or not. So, whenever in doubt, the dictum would be for most situations when in the emergency and when there is an emergency complication of diabetes happening, please choose insulin as the initial modality of therapy, and subsequently with the clinical condition maturing over a period of time, you could go ahead with the choice of other drugs based on the phenotype of the patient, based on the other accompanying history and other accompanying investigations. If you have access to antibodies and which can be done free of cost or very cheaply, then definitely as a part of various projects in several government hospitals, you can definitely go ahead with it. But if you don't have access to it, also please remember that treatment has to be started, and insulin would probably be one of the cornerstones of treatment. Now, in this context, I would also like to uh, take your attention to something which Dr. Mohan sir often says, or something similar to what I'm going to say. I may not be quoting his exact words, but if a patient can be put off insulin, a young patient can be put off insulin, especially in the genetic forms of diabetes, which we have talked about, and patient can be switched over to a sulfonylurea, why deprive that person of that opportunity? So there lies the importance of probably labeling the person also. But yes, the situation may not be the same in all places, and with the kind inputs of Ghoshal sir, I think we will probably understand that some of us may be lucky to work in a setup at this point of time where we have access to everything, maybe sometimes free of cost also, but everyone may not be having the opportunity. And in such scenarios, maybe in a rural setup where nothing is available and you cannot refer the patient also, or you cannot send the investigations also to the faraway labs. So, as a starting point, adequate hydration and management of the DKA with insulin could be one of the important steps. And then you can, as you build rapport with the patient and take him and his family, or him or her and his family, into confidence, you could gradually go on titrating the medications based on what comes out later on with the investigations. You could go on doing with that. But always you might not have access to everything, and there might not be a, as I mentioned, that one size may not fit all when we are talking about either the diagnosis or management of the various forms of diabetes mellitus. So if Ghoshal sir, is it fine, sir, or would you like me to go into any other point?
Well, sir, it was a very interactive session. It was very informative. Thank you.
Thank you, sir. Thank you, ma'am.